Yes, thank you. Rasmussen encephalitis is a rare disease of unknown etiology that causes severe chronic unihemispheric inflammatory disease of the central nervous system, mainly in children. It leads to intractable seizures, congenital decline, and progressive neurological deficits in the affected hemisphere. Here we present two cases of Rasmussen encephalitis as defined by 2005 Bain criteria. The diagnostic challenge of characterizing this rare disease will be highlighted by the extensive serum, CSF, MRI imaging, and EEG data in the two patients. The first case is an 80-year-old girl presented to our hospital with history of repeated episodes of clonic seizures involving right upper and lower limbs, and each episode lasting for 2 to 5 minutes with prolonged post-ictal state. The episodes didn't involve a sudden loss of consciousness, but she had a bladder incontinence. Neurologic exam showed right hemiparesis, constant twitching of the right hand, and intermittent stiffness of the right leg and pelvic. No history of neonatal seizures, blood transfusion, neurosurgery, TBI, proven allergic, and family history of epilepsy. EEG showed slow activity with focal left frontal paroxysmal discharges, as figure 2. MRI finding revealed left hemispheric atrophy in the left insular cortex. MRI T2 revealed atrophy in the left caudate and putamen nuclei, as in figure 1. So the diagnosis of Rasmussen encephalitis was suspected. She was given immunotherapy with immunoglobulin IEG for 1 dose, followed by methylprednisolone, followed by oral prednisolone. She slightly improved. She is currently on outpatient review and a more aggressive treatment, including surgical intervention, is being considered. Our second case is a 5-year-old male child presented with complaints of multiple episodes of clonic seizures of the left upper and lower limb since last 8 months. He was treated with anticonvulsant drugs. He had no history of blood transfusions, neurosurgery, TBI, proven allergies, and family history of epilepsy. Neurological examination showed left-sided hemiparesis with exaggerated tendon reflexes on the left side. Muscle power was grade 4 on the left upper and lower limb, but a full 5 on the right upper and lower limbs. There were no signs of meningeal irritation or cranial nerve deficits. CSF analysis was normal. PCR for HSF, EBV, CMV appeared to be negative. The patient had a progression to epilepsia partialis continue with 9 months after first focal seizure. MRI finding in FLAIR showed high signal intensity area in right temporal lobe. EEG, as in figure 4, showed slow activity and focal right frontal polyphasic spikes paroxysmal discharges. To slow hemispheric atrophy, anti-inflammatory treatment with tacrolimus was given. Despite regular IVIG dosing for approximately 6 months as well as AED therapy, the patient's epilepsy remained refractory. Functional hemispherectomy was performed by complete removal of the cortex and Y matter sparing basal ganglia. After surgery, child had mild episode of seizure. Unfortunately, he died because of meningitis. So we can discuss these cases. Rasmussen encephalitis was first described by a neurosurgeon called Rasmussen in late 18 and 50. Since then, variable clinical features and lack of understanding of cause have created dilemma in diagnosis and treatment of this disease. The clinical diagnosis criteria for Rasmussen encephalitis were proposed by Derry and et al. Until causes of Rasmussen encephalitis are known, it is difficult to anticipate how treatment will improve. Such a situation creates a therapeutic dilemma. Hemispherectomy is not favored because of inevitable post-operative functional deficits, but a real risk exists that treatments used to delay progression of the disease will differ definitive surgical treatment. In conclusion, Rasmussen encephalitis is a rare disease and should be suspected in any patient with refractory seizures and progressive unihemispheric cortical atrophy with motor deficit. Its recognition is important because early and timely intervention with surgery can improve patient outcomes. Thank you.